So patients always ask me, how is the lung cancer surgery going to affect their breathing? And I tell them that it really depends. A healthy young man who runs a marathon and comes in and has a part of his lung removed may not have any symptoms after a part of his lung has been removed. However, a frail elderly person who has advanced emphysema might have terrible lungs, and if we were to go in and resect or remove a part of their lung, they might be very symptomatic. So how a person gets through surgery and what they're like on the other side of surgery very much depends on the health of the lung and how much lung they have to start with and how much lung we have to remove. Those are the three factors that we put into the equation to figure out how people are going to be after surgery. And when we want to do it in a very scientific way, we measure with the pulmonary function testing what's called the FEV1 and the DLCO. And we can calculate how much lung we think we're going to have to remove based on where the tumor is and whether or not it requires removal of the whole lung or removal of a lobe of the lung or removal of a segment of the lung. We always want to do a good lymph node dissection, sampling the mediastinal lymph nodes and the nodes inside that section of the lung that's removed. But at the same time, we can calculate with a mathematical formula based on a patient's pulmonary function test and based on how much lung we're removing and subtracting that volume to create a new percentage of what their lung will be like after surgery. So if someone's lung function is 60% of how it should be predicted to be, then they're probably fit in general to take a lobe of the lung out. However, if someone's lung function before surgery is less than 40% of what it should be predicted to be before surgery, if we take away lung like a whole lobe, they might have trouble. And we tell the patient that if you have surgery in this circumstance, there is a higher chance that you might be on a ventilator after surgery, or there is a higher chance that you will be profoundly short of breath after surgery. And so we try to tell patients what to get ready for so that they can make the smartest decisions at the time of surgery, and even sometimes choose whether or not they want to have surgery at all based on their risk calculation. Sometimes we calculate that taking the lobe out might have been the right thing to do if they had perfect lungs, but because their lung function isn't so great, we might take less than what we would normally take to preserve lung tissue so that they aren't dependent on oxygen after surgery. And so all of these factors go into play, and these are critical conversations that patients need to be having with their provider, with their pulmonary doctor, and with their entire multidisciplinary thoracic lung cancer team. These are very important questions, especially for patients that are on the borderline.